Welcome to the module on substance use disorders among forced migrant populations in humanitarian settings. In today's lecture, we will review the epidemiology and context of substance use disorders in this very vulnerable population. We will explore the gaps and stigma associated with substance use disorders, specifically in the refugee population. Globally, 1 in 5 people with substance use disorders receive basic treatment. Reasons for this include limited capacity, low utilization rates, historical emphasis on standalone clinics, and stigma, which we will address in the next few slides. Stigma, limited capacity, and competing socio-political and economic priorities often take precedence, and substance use disorders are often not prioritized. Development of novel substance use disorder, educational curricula with a socio-cultural sensitive approach is a necessity in humanitarian settings. Forced migrant populations experience extreme mental and physical stress, trauma, abuses, and human rights violations, and subsequently have a high prevalence of post-traumatic stress disorder and major depression, among others. These situations can worsen or trigger pre-existing mental health disorders and substance use disorders. Refugee populations and humanitarian settings remain vulnerable to substance use disorders, yet they go largely unaddressed by issues including psychosocial distress, availability of substances, duration of displacement, competing priorities within the political realm, and stigmatization. Displaced persons experience risk factors for substance use due to traumatic events, socio-economic adversity, and disruption in social networks. The United Nations Office on Drugs and Crime, the United Nations High Commissioner on Refugees, and the World Health Organization have identified challenges and opportunities for the delivery of substance use treatment interventions, in addition to providing guidelines to enhance delivery of treatment in humanitarian settings. Substance use disorder treatment, prevention, and harm reduction are included in international guidelines, yet lack implementation. A socio-culturally sensitive approach to addressing substance use disorders and forced migrants offers unique opportunities to address these gaps and lessen stigma, particularly among human rights practitioners and advocates. Critical gaps in substance use disorder identification. Knowledge, prevention, and treatment exist in refugee populations in humanitarian settings. Implementation of novel prevention, screening, and treatment interventions is vital in these settings. Previous directives have included the engagement of humanitarian practitioners and people with lived experience. This can facilitate the creation of practical tools for the adoption of suggested interventions, further investigating the effectiveness and implementation of interventions for preventing substance use, providing treatment, and practicing harm reduction interventions. Multi-sector engagement is absolutely critical in addressing this problem. Who does this involve? From humanitarian practitioners to policymakers and various governing bodies, community members and displaced persons, and those who may be researching in the field. In 2022, the Reference Group on Mental Health and Psychosocial Support of the Interagency Standing Committee established a thematic working group on substance use in humanitarian settings via engaging mental health and substance use services in community settings. This reference group created training resources for community workers, focusing on substance use prevention, harm reduction, referral to treatment, and recovery management. Further implementation of directives to organisations on substance use prevention. For example, family skills interventions used in Afghanistan, Bangladesh, Jordan, Palestine, Serbia, and Ukraine. The WHO and UNODC, along with the UN High Commissioner for Refugees, have provided procedural guidance on treatment. However, it remains vital to remember that there are a myriad of treatment gaps and that many do not have access to these despite the proposed guidance. Examples of past and current efforts include family-based prevention interventions in Afghanistan. In Ukraine, long-acting buprenorphine was introduced for treating opioid use disorder in 2023 by Unit Aid. In 2021, Uganda implemented self-help programs for South Sudanese refugees and Problem Management Plus. In 2010, Thailand used screening and brief interventions for refugee populations. And in 2023, Zambia implemented common elements of treatment for Congolese refugees. In summary, the outlook on substance use prevention, recognition, and treatment and humanitarian settings revolves around a few key principles. These include the development of functional guidelines and evidence-based interventions that can be either applied universally or to specific populations. Feasibility and replication studies are crucial for longevity, understanding their efficacy and advocating for the essential nature of addressing this disease state. Consideration for creating these programs includes various social determinants of health, such as gender, consideration of stigma, delivery of trauma-informed care, and identification of inequalities, all with the goal of lessening harm.